At the outset, I would like to thank the organizing committee for giving me this opportunity. So quickly moving on to the basics of Bankart Repair, which is the most commonest cases which you will be starting off with your shoulder practice. I would like to share my difficulties which happened when I started my practice, so that it will try to clarify the doubts which is running in your mind. Now we know that the shoulder instability, shoulder is the most commonly dislocated joint, and 95% is anterior, 4% is posterior, and 0.5% is inferior. And in our treatment or method of handling patients with shoulder instability or even subluxation, we should know what is the mechanism of injury, and the methodology of assessing them is very, very important. Now, if you have a young patient with shoulder dislocation with the hand and abduction and external rotation to 90 degrees, then there is a very high chance that he is going to have an anterior labral repair, antero-inferior labral repair, which can be a soft tissue or a bony. If you have an elderly patient, 60 years above, having shoulder dislocation with the arm in hyperabduction, then there is more likely chance for him to have a Hagel lesion, not an anterior Bankart lesion. They may have a Hagel lesion. So that is how you have to assess the mechanism of injury. We should always keep in mind it can either be traumatic or atraumatic, and we should also be giving importance to the mid-range instability and end-range instability. Mid-range instability is where anywhere between 0 to 45 degrees of abduction and then external rotation, the patient just dislocates. If that happens, then the patient is having a bony component, which means that there is a loss in the anterior inferior glenoid. It can be a bony Bankart lesion, or it can be an anterior inferior glenoid erosion. And end range instability is the most commonest thing that you come across. Take it to 90 degrees, external rotation 90 degrees, the patient will have apprehension. Now, there are various classifications available for instability. Just to give you a clear thought, any patient who has a traumatic unidirectional dislocation with a Bankart lesion definitely needs surgery, no doubt in it. We get locked, or we tend to do surgery for patients who are having atraumatic dislocations, multidirectional instability. Never do surgery for these patients. Try to assess them, give them a proper rehabilitation. If they fail the rehabilitation for a period of between 3 to 6 months time, then you are justified in operating to stabilize the shoulder. That's the reason why this classification is very, very important. So you have two groups. One is a traumatic dislocator, second was an atraumatic dislocator. And the most important clinical test that we do in our day-to-day practice is the apprehension test. We do the anterior drawer test and the posterior drawer test. And in addition, any patient who comes with shoulder dislocation, I always tend to assess the posterior stability also. Always bring out the jerk test, posterior jerk test, check on the Kim's test, just to make sure that the posterior labrum is also intact. So these are the most primary tests which we try to do in patients who are having instability. In addition, always keep in mind there is shoulder laxity syndrome, and these tests such as the Gage's hyperabduction test and the sulcus sign is a part and parcel of your examination, and pay attention to these subtle signs which help in decision making. The most important risk factor for a patient to develop recurrence in shoulder dislocation is young age, male gender, high demand activity, and presence of bipolar bone loss. What is bipolar bone loss? Erosion or antero-inferior glenoid bone loss in addition with Hill-Sachs lesion. These are the two most important bony lesions which leads to recurrence, and these are the most important lesions which leads to failure following a Bankart repair. So you have to pay attention to this bone loss. Now the risk factors for a failure after Bankart repair is usually less than 30 years of age, male gender, pre-operatively the patient had more than 10 times dislocation, and involvement on contact sports, and presence of ALPSA lesion. So there are many antero-inferior lesions that are seen. The most important and dangerous one is actually the ALPSA lesion. We have to give specific attention to that. And then the presence of glenoid bone loss. So all these important risk factors should be running in your mind when you are trying to suggest any surgical procedure for a patient with an instability. Now the investigations of choice. As a routine, we can do these X-rays, standard AP view with shoulder internal rotation, which will show us the Hill-Sachs lesion, and the West Point views, which will give us the generalized outlook of the anterior and the posterior aspect of the glenoid, and helps us in giving us a quantitative assessment of the glenoid bone loss. But the investigation of choice is definitely MRI. You have to do an MRI scan. If you have the benefit of an MR arthrogram, it's good enough, but MRI is good enough, all right? Do an MRI scan, check whether the patient is having any anterior labral lesion, posterior labral lesion, associated Hagel lesions, and always this has to be supplemented with a CT scan. So whenever you are approaching a patient with shoulder instability, MRI and CT becomes an integral part of the investigation. Well, the reason is any patient who has more than 25% bone loss, which is very difficult to actually assess in an MRI scan. You can see that only in a CT scan. If you try to do a Bankart repair for this patient with more than 25% bone loss, then the chances of failure is very, very high. And that's where the concept of glenoid tracking and measurement of glenoid index plays a very important role. Now, what is glenoid index? You are trying to assess how much amount of glenoid bone stock is available. So the best way to do is actually, there are many ways. The one which I choose is the perfect circle method, where you draw a circle and then measure the entire diameter of the circle with a red line, all right? And then divide it by whatever is the presence of the bone stock available in the glenoid. Once you divide it, if the glenoid bone loss is more than 25%, always opt for a bony procedure. If it is less than 25%, we will further discuss on how to manage that. So the great stalwarts in shoulder surgery, Lefos, Bankart, Giacomo, Itoi and Sugaya have done n number of researches in their subgroups, around 100 to 150 patients, and they've got a significant number of failures as well. And it's because of their failures that we are learning how not to commit that, and we are actually evolving in this field. So we have to be always thankful to these great masters, because they failed in order to make us successful. All right. So they came out initially with all these failures. Pascal Bolo in France put forth what is called as ISIS score. The reason is they had been operating these patients with more than 20% bone loss and found out that they were failing. They wanted to find out, is there any other reason for the failure, and Bolo had put forth the ISIS scoring, and it was put forth into 10 points. Anything less than 10, the patient can definitely go in with a bony procedure. Anything more than 6, the patient needs scopy. But actually what happened was the IS score was not well accepted all over, and they wanted to further refine on how to do the decision making in choosing what procedure patient needs. And that's where the glenoid tracking concept came in, where E.G. Itoi and Giovanni Giacomo put forth tracking. Tracking is nothing but when there is no heel sac lesion, when there is no anterior glenoid bone loss, they both move in the same plane and there is no dislocation possible. When there is a heel sac lesion and a normal glenoid, the heel sac will not go and engage onto the anterior glenoid. So this is an on-track lesion. When there is an anterior Bankart lesion or any anterior glenoid erosion and the presence of heel sac, the heel sac goes and gets locked onto the anterior glenoid in the position of risk, that is at risk position. So this is called as an off-track position. Now, is it possible to measure this preoperatively? That's what they wanted to know, because before we advise any surgery, we need to know whether this heel sac lesion will go and get locked onto the glenoid or not. And that's when they put forth the glenoid tracking concept, where they said if the heel sac width is more than 83% of whatever glenoid you have measured, it means the heel sac is large. When the heel sac is large, when you take the arm into abduction external rotation position, it is going to get locked. So that's an off-track lesion. So any patient who has less than 25% glenoid bone loss, who has an off-track lesion, you have to definitely address the heel sac lesion. And hence, I usually follow this algorithm. So any patient who comes to you with anterior glenohumeral instability, check on the risk factors. The most important risk factor is presence of young age, male dominance, professional athlete and contact sport. If yes, definitely they need surgery, and that surgery will be decided on what is the amount of glenoid bone loss they have. If they have more than 25% bone loss, go for a bone block procedure. If they have less than 25% bone loss, check on the glenoid heel sac tracking. If the heel sac is an on-track lesion, which means the heel sac is not going to go and engage, so Bankart repair is good enough. If the heel sac is going to go and engage based on the CT measurement, then the patient needs a Bankart repair along with a rim plus arch. Very simple. If the patient is not into this risk factor, check on the possibility of recurrence, which means if the patient has 1 or 2 recurrences and above, if the patient has more than twice recurrence, then they need surgery. If they do not have any recurrence, then you can definitely manage them with conservative treatment in the form of appropriate muscle conditioning exercises and scapular strengthening exercises. This is the algorithm which I usually follow and found to be very successful in my hands. Now let's go into the arthroscopic Bankart repair. I always keep in mind these factors before addressing a patient for surgery, because this is one which is going to help me in being successful in whatever procedure I do. So anyone who is involved in contact athletes, I don't do a Bankart repair. I straight away go for a Latarjet. Anyone who has got associated high demand activity level, always a bony procedure. And the most important thing which we are actually missing in our practice is how to assess the labral quality. I would like to ask the same question to all the experts over here. It is just a subjective measurement. You try to pierce the labrum, you find that it's good, it is good. If you find it's not bad, it's not good, then you would say it's bad. But we don't have any preoperative measurement to assess the labral quality. And if we are able to do that, it guides us very well in deciding which patient needs what surgery. So far, I have searched in the literature, I am not able to find out anything. Now here's a case one. Is a 25-year-old male. He's a software engineer who has right shoulder instability for the past 5 years. Almost one episode every year, and he's had incomplete treatment, which means he dislocates, goes to the hospital, relocates, immobilizes for 3 weeks, does few exercises and then forgets it. He doesn't go for any investigation. He has an end range instability, mid-range range of motion is stable. All right. So I always position the patient in lateral decubitus, which gives me the comfort of having a good shoulder distraction. And I think Dr. Gopinath had mentioned everything about this clearly. The portals which I use is the posterior portal, posterolateral portal, the anterosuperior portal, and the anterior portal. I'm not going to talk about the remplissage because we have Dr. Ayyappan who's going to talk about remplissage, right? There is a talk on remplissage, so I'm not going to discuss in detail. Always start with a proper diagnostic arthroscopy. Check on the lighthouse, which is the biceps. Look into the rotator interval. Have a look at the subscap. You will have some amount of partial articular-sided derangement in the subscap because this is also involved in anti-dislocation. And take a look at the most important structure is the humeral attachment of the glenohumeral ligament. If you do not see the Hagel lesion, you are committing a crime, okay? Especially when you are doing a patient with a elderly age group, 60 years and above. If they need a surgery, if they have a dislocation, if the labrum is normal, then it's probably the Hagel lesion. Always make sure that the Hagel is visualized very well. Then a proper examination of the glenoid surface as well as the posterior labrum is very, very important. And then try to look at the bare area. The bare area has got the attachment of the infraspinatus along with the pores for the nutrient foramen, and also assess what is the dimensions of the heel sac lesion. So I go anteriorly and then have a look at the heel sac lesion, which confirms the diagnosis that the patient has got two essential lesions. One is the Bankart lesion anteriorly and the heel sac lesion posteriorly, which is resulting in this patient's symptoms. Now, next most important thing is establishing the portals. It's now that I'm viewing through the posterior portal, the anterior portal has to be established slightly lateral to the coracoid, and intra-articularly it should be as close as possible to the subscapularis. You can see the subscapularis over here, all right? And my needle should come in this area, okay, exactly over here, so that I have a good angulation and trajectory pointing towards the 5 to 6 o'clock position of the glenoid labrum, so that I place my first important anchor at the 5 or 6 o'clock position. Then, after establishing the anterior portal, I go to the, sorry about this. I go to the anterosuperior portal. Now, the anterosuperior portal is just right along the corner of the anterolateral corner of the acromion, but intraoperatively, it should come anywhere in the rotator cable area. This is the rotator cable area, and the most important point in this procedure is when you establish this portal, make sure that the needle is trying to come and reach up to the 6 o'clock, which means this is going to be the viewing portal. So you should be able to view up to the 6 o'clock position of the glenoid labrum. So that is very important. Once that is done, I go for the remplissage procedure. I put the anchors and take the bites. I'm not going to explain about that here. Then I'm viewing through the anterior portal. I'm viewing through the antero-superior portal. My working, this instrument is from the anterior portal. I try to detach the labrum. Now the labrum may be ill-defined. You will not be able to see. The best way to actually separate the labrum is first keep the instrument, the periosteal levator, close to the bone, and see, that's the demarcation. When you try to remove it, you will be able to separate the lesion and try to prepare the labrum for a proper reattachment. Make sure that you do not damage the bone. Go from proximal to distal, that is from the almost like from the 1 o'clock position to the 6 o'clock position, so that it will be easy for you to release the labrum from the anterior surface of glenoid. Now how much to release? Now you keep releasing as much as you are able to see the normal labral tissue. In this case, we are able to see that the normal labrum was seen only at the 6 o'clock position. So you have to release up to that position and make sure you are able to see the reddish subscapularis muscle underneath. Always you will have this bleeding. This bleeding shows that you are releasing adequate tissue. So you should be able to see the subscap. And this is the overgrown cartilage. Because of the chronicity, the bone is masked by an overgrown cartilage, which we will be releasing. So after the release of the tissue, I prepare the anterior neck. We have to make the surface raw so that whatever tissue goes and sits sticks onto it with a good bleeding vasculature. I also tend to release some normal tissue also. This is mainly to facilitate inferior capsular shift, because in a Bankart lesion or instability, the anterior inferior glenohumeral ligament slips down. You have to bring it up. You have to bring it up and then fix it. So that is called as inferior capsular shift. If you do a Bankart repair without an inferior capsular shift, then it's actually not a proper anatomical repair, and the chance of failure is quite high. Now, what is the ideal anchor placement? Now, ideally we were taught to have the anchor placement at 45 degrees, but there is a recent literature which says that you can either put it at 30 degrees, you can put it at 60 degrees, no matter what, whichever, anywhere between 30 to 60 degrees when you are using an all suture anchor is good enough. So you have to keep in mind it's at 45 degrees. The ideal anchor spacing is 5 millimeters between each anchor, and you have to place the anchor at try to be between 5 to 6 o'clock as the first anchor, and then every 5 millimeters above you can come and place the anchor, which comes to around 4 o'clock and 3 o'clock position. Now what I do here is, because of enormous bleeding which may happen in some time, I tend to mark where I am going to put the anchor with the electrocautery device, so that it aids in appropriate placement. Because once I put the inferior anchor, and when the labrum comes and sits onto that tissue, I may not be able to see the appropriate, the previous anchor. So these markings help me in guiding that. Next most important thing is, I use the electrocautery device and take off all the cartilage, and if I am lucky with the anterior portal, I can place it at the 6 o'clock position. In this case, I am able to place the anchor exactly at 6 o'clock position and use the suture passing devices and take the bites. If I am not able to reach up to the 6 o'clock position in this, like in the previous case, I use the posterolateral portal. You can see that the posterolateral portal over here, which was used for the remplissage, I put the instrument through the posterolateral portal, but on the inside of the shoulder joint, I come through the rent which was used for the posterior portal. So I am dead there. I am right at the 6 o'clock position, which is the ideal placement for the suture anchor. And then I retrieve the sutures and use the suture passing device from the posterior portal and take the bite in the 6 o'clock position. Now after this, when you have placed your anchor properly, you have to take bites through the tissues. First bite should be at the 6 o'clock. The second bite should be at the 5:30 position. Once you have done that, you can tension the knots as per Dr. Mahesh Krishnan explained, based upon the inferior capsular shift. You have to bring the tissue back onto the glenoid surface. At the same time, you should be pulling it from inferior to superior. And then you can use whichever knot you want, either Nicky knot, Revo knot, whatever it is. All you want is the labrum to go and sit onto the glenoid surface properly. Simple. Whether to use a simple stitch or a horizontal mattress, Literature says that a horizontal mattress stitch ensures a good bumper effect, but we have been very comfortable with a simple stitch which has given us a good result. So whatever stitch configuration you are comfortable with, you do it, as long as the labrum is coming and sitting properly onto the glenoid surface. That is very, very important. If you do that and sequentially tie the labral tissue one by one, you will be able to visually see the good repair which has happened in the 5 o'clock position. Now with the first anchor, the 5 o'clock area I have repaired properly. When you have done that difficult part, the remaining 2 anchors, when you place and take the tissue bites through the capsular tissue, it is an easy job for you. You don't have to struggle for that. So what initially happened looked like a very pathetic tissue. You are not able to appreciate properly. After the release, you were able to differentiate the tissue from the abnormal tissue, and at the end, you are able to achieve a very good Bankart repair. So we usually follow the rehabilitation which we have published in the Asian Journal of Arthroscopy. You can look into it. So the summary, you have to have an ideal history and case selection. In the case selection itself, you should know whether the patient needs a scopy Bankart or a Latage. MRI and CT is absolutely mandatory. The success of surgery depends upon the optimum portal placement, and always get the first anchor at the right position. 6 o'clock anchor, you need to get it either through the anterior portal or the posterior portal. Inferior capsular shift is a must in ensuring the success of your repair. Ideally use 3 or more anchors, not less than 3. Definitely 3 and more anchors. You can either choose a simple or a horizontal mattress stitch. Thank you.